close on the side that we're side bending them to, then they're flexed, side bent, and rotated to the opposite side of the restricted motion. Yes, absolutely. I hope I can remember what I just said. Play it back, please. One more time. So, when we're assessing with the bias of extension, okay, and we're in extension, and we're side bending towards the right. So, we translate left, we're side bending towards the right. We have side bending right, rotation right. If we feel that there's a limitation there, we know because it's an extension bias and it doesn't want to extend that it has to be flexed. And the diagnosis of that would be, if I was trying to do it, if I was extending and side bending right, rotating right, it would be an FRS to the where? To the left. If I did the same thing, went down to the mid-cervical or lower cervical spine, had an extension bias, and I translated right, causing left side bend and left rotation, and I felt that it was limited and restricted there, I can say that that segment is most likely FRS to the, because the left facet can't, in the extension, side bend, and rotation I'm asking it to do. All right?
Do you usually, is it usually an extension bias in the lower cervical?
It differs because of the lordosis. I often find a lot of extension lesions in the higher lower cervical spine, so C2s, C3s, where I find a lot of FRSs that are very common, 4, 5, 5, 6 especially. All right, so let's show you what that looks like quickly on the skeleton. And then I'll have somebody come up so that you can kind of get a feel for what it is. Yeah, let's do that. So here, what we want to do is we want to bias the spine in extension. Okay? So we're first going to get our locations. And that's the most important thing, so you know that where you are. You're going to come down from the occiput. And the first spinous process that you're going to feel below the occiput is the spinous process of what vertebral body? C2. So I now at least have a locator to find out where I'm starting. What I'm now going to do is I'm going to go on the what's called the articular pillar of C2, which is nothing more than the lamina, actually. And I'm going to rest my fingers there, make my contact with my index finger and my middle fingers. I'm going to get my elbows out to the side so that when I do my translation, I can keep an eye on the side bend component as well. So in extension, I side bend, translate left, I side bend right, rotate right, and I'm assessing for the right facet to close. I come back to midline, I translate right, side bend left, causing rotation left. I assess for the left facet to close. So again, when I translate left, I side bend right. Which facet am I looking to see if it closes?
Right.
Right, because I'm in extension. And we know that the facet should close in extension. I come back to midline, and I try translating to the right, side bending left, but I'm not going as far at this level. So I have limitation in extension, side bending, rotation to the left, which then means positionally C2 must be what? FRS right, because the left facet is not closing and allowing extension, side bend, rotation to the left. Right?
Don't say right, say correct.
That's, yeah, I know, I usually catch myself. I just said that, like, oh God, no, don't say right. Good with that? Okay. Now, what I would do is segmentally go down and do the same thing. 2, 3, I found my restriction. 3, 4, in extension. Check for the end field. 4, 5, check for the end field. 5, 6, 6, 7, 7, T1. Now I've assessed the whole spine with an extension bias, checking for what osteopathic lesion. Yep, it's in an extension bias, so I'm checking for closure arthrokinematically. What osteopathic lesion am I looking for in my extension bias? An ERS or an FRS? FRS, very good. Yeah, sometimes if you'll hear somebody say an osteopathic lesion, they'll be referring to the ERS-FRS component, right? So now that we're done, right? Nothing else is, oh, wait a second. We forgot to check flexion. We've got to do flexion, right? Okay. Because our spine does do flexion. And when we're in I'm just trying to make it interesting. So, the reason why we have to assess for flexion is we have to assess for the lower cervical facet joints to see their ability to do what if we're going into flexion? Open. Open. Guys, I saw a few of them mouthing the word to me. Yes, it's open. So, in order to assess that, we find, again, our safe landmark again, which is always going to be C2 spinous process. Come down off the occiput. Jamie, we'll thrust that later on today, don't worry. So, we'll come down here, find the spinous process, and what we want to do is get between the spinous process of C2 and C3, find the lamina of C2, right here, bypass the muscle tissue to get to it, sink into the facets. You're going to bias it up into a little bit of flexion. I'm going to raise the table for this. I'm going to use my belly to rest the head on again. So I come up into a little bit of flexion. And again, with translation left, I cause side bending right. By doing this in a flexed position, I'm assessing which facet joint to open. The left. Come back to neutral. I translate to the right, causing side bending left in flexion. Which facet joint am I challenging? The right. Excellent. So, if I found a limitation in flexion, side bending, rotation to the left, in other words, trouble getting into flexion, side bending, rotation left, I must be stuck extension, side bend, rotation on the right, which is why I'd have the diagnosis of the ERS right. C2-3. Should do that again? Go ahead, Frank.
Is it more common for the ERS to use the diagnosis?
In my experience, and I think Dr. Greenman mentions it as well, I just can't remember it between him and Mark Bookout's lecture. But, bless you, we tend to see because of the curvature, and I'm going to overdo the curvature here just for the sake of demonstration. Where do you think that you're going to see more of the extended lesions? Upper. Where do you think you're going to see more of the flexed lesions? Lower. And C4, C5 tend to be that transition zone. So I don't want you just to be led by the anatomy. I want you to really be led by end field. Okay? So if I were to continue down now, we already hit C2, 3. We're going to do 3, 4. Get into the same position. I'm on the superior segment, so I'm on C3. I'm in a flex position, translate left, causing right side bend, right rotation. I'm checking the ability of which facet to open. If I'm side bending right and rotating right. The left. Come back to neutral, do the same thing. I translate right, causing side bending left, rotation left. I'm assessing which facet's ability to open. The right. And I do the same thing at 4, 5, 5, 6, 6, 7, 7, T1. All right? Let me have somebody up here. I'll show you what it looks like with the human sample, and then we'll go and break into that. Danielle, thank you. So we first started with extension, right? So I first find my landmarks. Occiput, sink down. I don't feel the spinous process, but I know C1's right there. And boom, I'm on C2. I find my way over onto the articular pillar, which again is right along where the lamina is. Okay. I sink into the tissues, and I start with a bias of extension. Just extension to that level. Elbows are out to the side. I translate left. I see for the ability for the right facet to close on the right. Come back to neutral. I look for the now ability of the left facet to close by translating right, causing left side bending, left rotation. And I assess it to see how it is from left to right. I then go down to the next level, so now I'm on the level of C3. Translate left, cause right side bending and rotation. Come back to neutral. Translate right, cause left side bending and left rotation. Looking for restrictions of motion all the way down the spine. If I were to find a limitation extension and left side bending and rotation, where would my positional lesion be located? It would be, if I can't extend side bend and rotate to the left, what must I be? I must be flexed, side bend, rotated to the right. Exactly. Because the left facet can't close. And we're in the extension bias, and that's what we're asking it to do. For the flexion component, I can flex up, find C2, rest the head on my belly. Come across, translate, translate. Next level, translate, translate. Next level, translate, translate. Did you feel that one? Mm-hmm. Yeah. So she's limited, if you don't mind me saying it, C4 with right side bending, right rotation. So if she can't flex, side bend, rotate right at C4, what is her osteopathic lesion? She's a...
Wait, you're an extension now, right?
Nope, inflection.
Oh, you went to flex.
Yeah, sorry. She's a, you said it. ERS left at C4. So if I come over to C4, there it is. It's stuck. But that's the way you're going to do the assessment. Now there's a lot of different ways we can treat it, but we've got to do the assessment first. We're going to bang that out and then go right into treatments for the rest of the lab. Anyone want me to show something again or talk through something again before we go? You can certainly wait till you have your hands on and maybe some questions come on at that point, but I think you're going to get the idea because the translation's the same as what you were doing, you're just at a different level. And now you have to start thinking about the FRSs and ERSs. Remember, when you're in extension bias, you're looking for FRSs. When you're in flexion bias, you're looking for ERSs. Just make sure you remember which facets are the problem facets. That's where people always get a little confused with this technique. And this is a substitute to the seated technique that you're already doing and doing so well. So it's nice because it lets them relax too, and you do get that freedom of motion with that translatoric assessment. Thanks. Let me lower it down.
Thank you.
Yep, you got it. All right.